We're now going to begin to review the general surgery vignettes. We're going to start with diseases of the gastrointestinal tract. And we begin with the upper GI tract, specifically with the esophagus. Vignette number 1. A 62-year-old man describes epigastric and substernal pain that he cannot characterize well. At times his description sounds like gastroesophageal reflux, at times it does not. Sonogram of the gallbladder, EKG, and cardiac enzymes have been negative. So the question seems to be in this vignette, why is the patient having that pain? Somebody already thought, maybe coronary pain. Well, no, that didn't prove to be the case. Maybe gallbladder. No, that didn't prove to be the case. And the question then arises, is the pain perhaps due to acid reflux? And in that case, your best answer then would be provided by pH monitoring. Patients hate this, but it will give the answer. You put a little probe that ends up at the lower end of the esophagus, is connected to a machine that records the pH. The patient is instructed every time he feels pain to push a button and make a marker on the tracing. When the tracing is eventually reviewed, if every time he said, I'm having pain, his pH in the lower esophagus was 1, and at other times it was 7, then we have established the fact that it is acid reflux that gives him the pain. And then we could proceed with the rest of the workup. Now, as we go on to the next vignette, though, you realize that there are times when you don't need to do this pH monitoring. Vignette number 2. A 54-year-old obese man gives a history of burning retrosternal pain and heartburn that is brought about by bending over, wearing tight clothing, or lying flat in bed at night. He gets symptomatic relief from antacids, but has never been formally treated. The problem has been present for many years and seems to be progressive. This description is classical for gastroesophageal reflux disease, GERD. You don't need pH monitor to tell you what's happening. You know what's happening. And your concern, given the description on this patient, is what damage has been done to the lower esophagus. And so the test you want to do next is endoscopy and biopsies. Well, now let's pursue that theme. Vignette number 3. 54-year-old obese man gives a history of burning retrosternal pain, heartburn that is brought about by bending over, wearing tight clothing, lying flat in bed at night. He gets symptomatic relief from antacids, but has never been formally treated. The problem has been present for many years, seems to be progressing. Endoscopy shows severe peptic esophagitis and Barrett's esophagus. Let's talk about this. There was a time a number of years ago when anybody who was diagnosed with Barrett's esophagus was advised to have surgery because Barrett's was feared to be a precursor of cancer. But that was in the days before we had effective medical management, which we now have, thanks to proton pump inhibitors and good pharmacological therapy. And so the key phrase on this vignette, I'm going to read it again, because you may not have caught the meaning of that when I first read it. The key phrase on this vignette is the one that says he gets symptomatic relief from antacids, but has never been formally treated. So if he has never been formally treated, it's time for him to be formally treated. Medical management. He needs to go under the care of a good gastroenterologist that, with the use of proton pump inhibitors and other medical means, will control the reflux and will take care of the damage that was done to the lower esophagus. On the other hand, let me now read vignette number 4. A 54-year-old obese man Gives a history of many years of burning retrosternal pain and heartburn that is brought about by bending over, wearing tight clothing, or lying flat in bed at night. He gets brief symptomatic relief from antacids, and now comes the key phrase. But in spite of a faithful adherence to strict program of medical therapy, the process seems to be progressive. Endoscopy shows severe peptic esophagitis or no dysplastic changes. Surgical treatment has been recommended. Now that is an indication for surgery. It is appropriate that surgical treatment has been recommended because he already had the medical therapy to which he adhered faithfully. He failed the medical therapy trial. The surgery would be, if he has no dysplastic changes, as I read, it would be a fundoplication. If it had said that he had severe dysplastic changes, he would have required a resection. And I might add, prior to that operation, just about every test we can do in the esophagus will be done, because a surgeon will want to know exactly what is going on before an operation is undertaken. We move now to vignette number 5. A 47-year-old woman describes difficulty swallowing, which she has had for many years. She says that liquids are more difficult to swallow than solids, and she has learned to sit up straight and wait for the fluids to make it through. Occasionally, she regurgitates large amounts of undigested food. Now, we have a patient with difficulty swallowing. But as you read the vignette, you immediately knew this was not a cancer of the esophagus. Because in cancer of the esophagus, the typical sequence is at first you cannot swallow solids, and eventually you cannot swallow soft food, eventually you cannot swallow liquids, and so on. And here you have the opposite. A lady telling you that she's got more trouble swallowing liquids than swallowing solids. And that immediately tells you this is a motility problem. It's not a cancer, it's a motility problem. And the rest that I read, the age, the gender, the regurgitation of undigested food, tells you that this is probably a chalasia of the esophagus. You're going to begin the workup with a barium swallow. In fact, let me give you a little tip here. Anytime an exam question says a patient has difficulty swallowing, probably the best test to begin with is going to be barium swallow. You may need to add other tests afterwards, but the barium swallow provides you some safety before you do more invasive things. And you're not likely then to perforate the esophagus by putting other instruments in there. If you do the barium swallow in this lady, it will show the mega esophagus. This explains why she has undigested food on the pillow. This explains why she has learned that she can sit up straight, fill that mega esophagus with fluid, and then the hydrostatic weight, the pressure of that fluid will open the sphincter. Eventually, you're going to follow with manometry, because manometry provides you the fine-tuning and the diagnosis of a motility problem. And finally, in terms of the therapy, it can be dilation, which would have to be repeated from time to time. The lady would be taught how to self-dilate the esophagus. She would swallow a bougie and dilate her esophagus. Or it could be surgical therapy, or we go ahead and open the lower end of the esophagus. Now, as we move into vignette number 6, we're now going to see the pattern that you recognize as cancer. A 54-year-old black man with a history of smoking and drinking describes progressive dysphagia that began 3 months ago with difficulty swallowing meat, progressed to other solid foods, then soft foods, and is now evident for liquids as well. He locates a place where the foot sticks at the lower end of the sternum. He's lost 30 pounds of weight. This is a cancer. Given the background, smoking, drinking, probably squamous cell carcinoma. And the background had been protracted reflux, Barrett's esophagus, dysplastic changes. It would have been an adenocarcinoma. In either case, let's begin with the barium swallow. because the eventual diagnosis, in fact, will be done with endoscopy and biopsies, but the endoscopist wants to know how far down is the cancer, how much looming is left, because that endoscopist fears that he or she may perforate the esophagus with the instrument. And the barium swallow ahead of time gives a road map that makes it less likely that a perforation would occur. And so then, after the barium swallow, we do the endoscopy, we take the biopsies, we follow that with a CT scan to see the extent. They are typically extensive by the time we recognize them, and to choose the therapy, which in most cases, unfortunately, is only palliative surgery. We now have two vignettes that begin in a somewhat similar pattern, but lead to two different outcomes. Vignette number 7. 24-year-old man spends the night cruising bars and drinking heavily. In the wee hours of the morning, he's quite drunk, starts vomiting repeatedly. He initially brings up gastric contents only, but eventually he vomits bright red blood. This is a very common thing. This is a famous Mallory-Weiss tear. A little tear of the mucosa of the gastroesophageal junction produced by the repeated vomiting. You do an upper GI endoscopy, you see the bleeding point. If needed, you use laser therapy to coagulate it. Vignette number 8 begins in a similar way, but has a different ending. A 24-year-old man spends the night cruising bars and drinking heavily. In the wee hours of the morning, he's quite drunk, starts vomiting repeatedly. Eventually, he has a particularly violent episode of vomiting, and he feels a very severe wrenching epigastric pain and low sternal pain of sudden onset. On arrival at the ER 1 hour later, he still has the pain, is diaphoretic, has fever and leukocytosis, looks quite ill. This is a perforation of the lower esophagus produced by the repeated vomiting. This is the Behr-Have syndrome. Prompt diagnosis is essential for a patient with a perforation. You do that by giving the patient a gastrographing swallow. So you demonstrate the presence of the perforation, but the gastrographing doesn't irritate the mediastinum like barium would. And so rather than asking for a barium swallow, you ask for a gastrographing swallow, and then as quickly as possible, that rent in the esophagus has to be repaired. Let me repeat these issues brought up by this vignette. I'm going to cut away from my face and go to a little kind of the decision tree here. If we have a patient with difficulty swallowing, if liquids are more difficult to swallow than solids, we're probably dealing with a motility problem. If there is a progression from solids to liquids, we're probably dealing with cancer. Let's continue this topic. If we think it is cancer and there is a long-standing history of smoking and drinking, it's probably squamous cell carcinoma. And if we think it's cancer, but the preceding history is long-standing reflux, Barrett's, and dysplastic changes, we're dealing with adenocarcinoma. In either case, let's start with a barium swallow to make subsequent invasive studies safer. Motility problem is suspected, you follow with manometry. Cancer is suspected, you follow with endoscopy and biopsy, and then CT scan. Here is a picture of a patient with achalasia with the mega esophagus, visible in fluoroscopy. And here is a picture of a cancer of the esophagus on a barium swallow. Now the next little reminder here, we've already talked about this. A patient who spends the night cruising bars and drinking heavily, and he then has protracted forceful vomiting, and then something happens. If there's something that happens is vomiting bright red blood, the problem is a Mallory-Weiss tear, we do an upper GI endoscopy. But if the thing that happens is horrible chest pain of sudden onset, fever, a very sick-looking patient, it's esophageal perforation. It's the Bear-Have syndrome. Do gastrography and swallow and repair promptly. Let's now move to vignette number 9. A 66-year-old man has an upper GI endoscopy done as an outpatient to check on the progress of medical therapy for gastric ulcer. 6 hours after the procedure, he returns, complaining of severe, constant retrosternal pain that began shortly after he went home. He looks prostrate and very ill, is diaphoretic, has a fever of 104, a respiratory rate of 30, and there is a hint of subcutaneous emphysema at the base of the neck. This is another example of esophageal perforation. Obviously, in this case, it was not produced by repeated vomiting. It was produced by the endoscopy. This is an iatrogenic complication. You need prompt repair. And so this patient needs the gastrograph and swallow to find exactly where the perforation is. We already know he has a perforation. You know, with this history, the presence of emphysema at the base of the neck, this air in the tissues, is pretty much diagnostic. There is an esophageal perforation. But we need to know where it is, so we do our proper surgical approach to repair. So you do the gastrograph and swallow for that. Now we move to the stomach. Vignette number 10, a 72-year-old man has lost 40 pounds of weight over a 2 or 3 month period. He gives a history of anorexia for several months, of vague epigastric discomfort for the past 3 weeks. I'm not sure that I can tell you what this is. It could be cancer of the stomach, but it could be a peptic ulcer, it could be something else. But I know what to do. Because anytime we think something is wrong with the stomach, our study of choice is endoscopy and biopsies. Upper GI endoscopy. It doesn't need to be preceded by a barren swallow, because this patient is not reporting difficulty swallowing. We do not expect that the instrument will have any problem going down the esophagus. And that instrument is not going to perforate the stomach. The stomach has plenty of lumen and a very strong wall. So do endoscopy and biopsies. If you find a cancer, follow with a CT scan to determine operability and hopefully operate either for a cure if we can, or if not, for palliation. We're going to begin now to review vignettes that deal with the lower gastrointestinal tract. We're going to start with the small bowel, eventually the appendix. This is vignette number 11. A 54-year-old man has had colicky, abdominal pain, and protracted vomiting for several days. He has developed progressive, moderate abdominal distension, has not had a bowel movement or passed any gas for 5 days. He has high-pitched, loud bowel sounds that coincide with the colicky pain, and X-rays show distended loops of small bowel and air fluid levels. Let me stop right here, because what I've read is a classical description of mechanical intestinal obstruction affecting the small bowel. And the last line is going to tell us why does he have it. 5 years ago, he had an exploratory laparotomy for a gunshot wound of the abdomen. So our assumption is this man developed adhesions as a consequence of prior surgery, and because of the adhesions, he now has intestinal obstruction. But to know the management of these, we have to reflect a little bit more on what was the sequence of events here. If he had an exploratory laparotomy 5 years ago, he developed the adhesions 5 years ago, because adhesions in the abdominal cavity are part of the healing process after a laparotomy. And yet for 5 years, he hasn't had any symptoms. He's eating 3 meals a day, his having bowel movements, doing fine. And now for a few days, he's in trouble. So what happened now? Did the adhesions become malignant? Did the adhesions grow? Did the adhesions get mad? No. The adhesions have been there all along. He simply ran out of good luck. For 5 years, even though the traps were there, the bowel never fell and got trapped. Now it did. Because we know that's a sequence of events. We don't begin the management by taking this patient to the operating room to undo the adhesions. We put an nasogastric tube, put it to suction, give him nothing to eat, IV fluids, and we wait to see if the bowel will get out of trouble as it got into trouble. And in most cases it works. But while we do that, we need careful observation because a complicating event could ensue. Let me read the next vignette. It begins the same way as the previous one. 54-year-old man has had colic abdominal pain, protracted vomiting for several days. He's developed progressive moderate abdominal distension, has not had a bowel movement or passed any gas for 5 days. He has high-pitched, loud bowel sounds that coincide with the colicky pain. X-rays show distended loops of small bowel and air fluid levels. 5 years ago, he had an exploratory laparotomy for a gunshot wound of the abdomen, and here comes now the new event. 6 hours after being hospitalized and placed on nasogastric suction and IV fluids, he develops fever, leukocytosis, abdominal tenderness, and rebound tenderness. He now has signs of strangulated obstruction, namely the loop of bowel that was caught is now losing its blood supply. The blood supply is compromised. He now needs an emergency operation. All right, let's move to vignette number 13. A 54-year-old man has had colicky abdominal pain and protracted vomiting for several days. He has developed progressive moderate abdominal distension, has not had a bowel movement or passed any gas for 5 days. He has high-pitched, loud bowel sounds that coincide with the colicky pain, and X-ray shows distended loops of small bowel and air fluid levels. So you again recognize the clinical picture, the description of mechanical intestinal obstruction of the small bowel. But now in the next few lines, we'll recognize there is a different reason for it. On physical examination, a growing mass is noted, and he explains that he used to be able to push it back at will, but for the past 5 days he's been unable to do so. So the problem now is not adhesions like it was on the previous vignette. The problem now is a hernia, an inguinal hernia that has become incarcerated, potentially strangulated. Now there is a big difference in the management between these two cases. In the previous situation where the patient had adhesions, we recognized that it would have been futile to operate on him to, quote, remove all the adhesions because they would have formed all over again. And so in the previous vignette, we operated that patient only if he didn't respond to the conservative management or if he developed strangulation like he did on the second vignette. But on this case that we're now reading, where the patient has a hernia, we can fix the hernia. We can correct that anomaly so he no longer is at risk for having a loop of bowel trap there. And the only question is, when should we do it? And I'll give you a few scenarios that will make sense. If the vignette were to say that he has fever, leukocytosis, that growing mass is tender and the skin is discolored, you will realize that he has strangulated obstruction. That loop of bowel is dead or dying, and he would require immediate emergency surgery. But if on the other hand the vignette were to say he has no fever, he has no leukocytosis, the mass is not tender, it's not discolored, but he is very dehydrated, then you would want to hydrate him first and then eventually do the operative intervention. And I might add, if he has no signs of strangulation, if he's not particularly dehydrated, and in the process of examining him, that hernia is in fact reduced, it gets pushed back into the abdomen, he still needs an operation so he doesn't have a problem in the future, but it could even wait for a day or two until he fixes his own personal affairs and so on, and then At a more convenient time, he has the hernia repaired. We now move to vignette number 14. This may sound a little bizarre as I read it, but we'll make a diagnosis. A 55-year-old woman is being evaluated for protracted diarrhea. On further questioning, she gives a bizarre history of episodes of flushing of the face with expiratory wheezing. A prominent jugular venous pulse is noted in her neck. When you look at this whole constellation, you know, or you should know right away, this is the carcinoid syndrome. This lady has a small carcinoid tumor, most likely in her terminal ileum. It makes serotonin. But as long as the tumor was confined to the terminal ileum, the serotonin that was dumped into the circulation went through the portal vein into the liver, was detoxified by the liver, and never made it into the systemic circulation. She had no signs from that. Eventually, she develops liver metastasis. Now, when the liver metastasis makes serotonin, they dump the serotonin into the inferior vena cava, and now they are systemic signs. And that's the wheezing, and that's the diarrhea, and that's the flushing that she's complaining of. And there is even a little extra. When that serotonin passes through the lungs, it gets to some extent detoxified, not completely as the liver would have done. But the bottom line is the concentration of serotonin is higher on the right side of the heart than on the left. And the serotonin damages the heart valves, but because of the difference in concentration, it has damaged those on the right, either the tricuspid or the pulmonary, most likely the tricuspid. That's why she has that prominent jugular venous pulse, because she has tricuspid insufficiency. So this is the carcinoid syndrome. You make the diagnosis by measuring 5-hydroxyndolacetic acid in the urine. Anytime you have a question on the exam that gives you a presentation that happens not as a steady symptomatology, but as attacks, as spells, like this lady, you're better off not measuring the offending substance in the blood, because it will not be high if the patient is not having the symptoms. But if you do a 24-hour urinary collection, you're going to catch the breakdown products regardless of when during the day did she have the episodes of flushing of the face and wheezing and all that. So urinary collection, 5-hydroxyndolacetic acid, it will be high. And then a CT scan of the liver will recognize the liver mets. And if at all possible, we will resect those liver mets. This is a malignant tumor, the carcinoid, but very slow growing. And if we remove the liver mets, she'll be a lot more comfortable and may live a good many years before the tumor eventually kills her. And now we move to vignette 15. A 22-year-old man develops anorexia followed by vague periumbilical pain that several hours later becomes sharp, severe, constant, and well localized to the right lower quadrant of the abdomen. He has abdominal tenderness, guarding and rebound to the right and below the umbilicus, temperature of 99.6, a white count of 12,500 with neutrophilia and immature form. A classic case for acute appendicitis. And if it is indeed a classic case like I just read, the answer is emergency appendectomy. No diagnostic studies, emergency appendectomy. If it were not a classic case, if you were in doubt whether it is appendicitis or not, your answer then would be a CT scan. Let me review again with you why I'm saying this is classic. Classic acute appendicitis, you first have the vague periumbilical pain, later it moves to the right lower quadrant. In the physical exam, you have the tenderness, the guard, and the rebound only to the right and below the umbilicus in the classical case, like this one. And even the fever range and the white count range given is classical. So this vignette, the answer is do an emergency appendectomy. If you had something similar but not clear-cut, the answer would be CT scan.